Hello, everyone, and welcome to SoftFil Academy's first webinar of the year. We are thrilled to welcome all of you. We are waiting like just a few seconds for everyone to connect. Just to give you the program very quickly, we are going to listen to Dr. Weiner's presentation for approximately 40-45 minutes, and then we will answer all of the questions. Please note that this webinar is being recorded and it will be, of course, as usual, available on replay on our website and on our YouTube channel. So you will be able to watch it again anytime you want. Please don't hesitate to let us know where you're from and say hello from the chat. We're always happy to hear from everyone. If you can maybe switch slides.
Okay.
All right, so today we are welcoming Dr. Steven Weiner. We are so thrilled to have you with us tonight. Thank you so much. I'm sure everyone already knows Dr. Weiner, but I'll do a short presentation. He is the creator of the aesthetic clinic. He is world renowned for his filler techniques using cannulas and his rejuvenation procedure, which he performed on the Doctor's Show. He served on multiple advisory boards, participated in FDA trials, and authored several clinical papers. He is #1 trainer for Galderma for the past 3 out of 4 years. He was voted one of the top 100 aesthetic injectors in the US and is on the Real Self Hall of Fame. He was awarded the best aesthetic practice in the US in 2018 at the Aesthetic Show. And he was awarded Best in Destin in 2019, 2020, 21, and 22. So we are honored to have you tonight. The theme of the webinar tonight is temple injection technique with SoftFil cannula and ultrasound. We are very excited for this webinar. Thank you so much. And I will now leave you to start your presentation, Dr. Weiner.
Thank you very much. Thank you for inviting me for this great webinar. And I'm a huge fan of using SoftFil cannulas, as you know. So first, let's talk about the temple anatomy, because that is key when you want to do your safe injections. So the very first layer is going to be, is the skin, okay? And then the next layer is the subcutaneous fat, which is here. So skin here, fat here. Next layer is the superficial temporal fascia, which is right here. It's also known as a SMAS. It's also known as the temporal parietal fascia. And then there's another layer, and that's the interfascial plane, also called the innominate fascia. And you can see running through it is the facial nerve, the frontal branch of the facial nerve. The next layer is the superficial layer of the deep temporal fascia, which is right here. So the deep temporal fascia splits into a superficial and a deep layer. And within that within those two layers is called the intermediate temporal fat pad, which is right here. And what you're seeing here is the middle temporal vein. Then you have that deep layer of the deep temporal fascia. It's kind of confusing. Here's the deep layer of the deep temporal fascia, okay? And then you have the deep fat, okay, or the buccal fat, which is right here. And then you have the temporalis muscle, and then there's periosteum, and then there's bone. So this is a little bit confusing. This is another way to view the different layers of the temple. But the reason I chose this one was to show you the septum. So this is called the inferior temporal septum, and this is the superior temporal septum. And most of our enhancement is going to be between the two septums in the upper temporal compartment, which is right here. So let's show you what ultrasound looks like of the temple. And so on the left side, you see the pulsing artery, which is a superficial temporal artery. That's the anterior branch. That lays within that SMAS layer, or that temporal parietal fascial layer. Okay, and then there is the intermediate temporal fat, and that's bounded by the two fascial layers, as I told you, the deep layer of the deep temporal fascia and the superficial layer of the deep temporal fascia. And then lying all the way deep to that is the temporalis, and then the temporal bone here. So the area that I like to inject is in between the two fascial layers. The fascial layers are where the superficial temporal artery is, and that superficial layer of that deep temporal fascia called the interfascial plane. So we'll go to the next slide here. So the venous anatomy, so the veins drain through the sentinel vein, which pierces through the superficial layer of the deep temporal fascia into the middle temporal vein. And you can tell it's a vein because it's compressing. And what I'm doing with the ultrasound probe is pushing on the skin, and you can see that the flow in that vein diminishes. So if it were an artery, it doesn't compress as easy. So the most popular way to inject the temples is in that deep injection. And I'm going to tell you that there's a lot going on in that area. And so this is where most people would be injecting, but I'm going to tell you that it's not as safe as other areas in the temple. Okay, why is it so popular? It's because it's easy. Okay, normally when you want to inject, you want to stay a plane away from the artery. And right here, we're dancing around the arteries in the same plane that we're injecting. So it's quite dangerous in my opinion. Okay, these aren't necessarily SoftFil's opinions. These are all my opinions here. This is another artery that's often deep in the temporal fossa called the zygomatical temporal artery. Okay, again, look where my probe is. The probe is exactly where you would be injecting. So I'm going to show you a different way. So to further that discussion, I'm going to go over a paper that was recently published by Dr. Nicholas and Kodafana and others in December. And what they did is they measured the distance of the anterior branch of the deep temporal artery. So there's two branches, an anterior and a posterior. And there's also further branching of that. But they measured it from the zygomatical rim right here. Okay, so generally what is taught is 1 up, 1 over. So 1 centimeter away from this area is generally where you inject. But look at the data over here. Okay, the data showed the artery at 1 centimeter, at 1 centimeter, at 0.9 millimeters, or 0.9 centimeters, 0.9 centimeters, 0.8 centimeters, 1.3 centimeters. So all around the area that you were injecting, supposedly safe, isn't quite safe. Here's another diagram showing that when you're injecting on the periosteum, you aren't necessarily safe as well. You could think that you're not in the area of an artery, but the bevel could be within the artery. It could be angled or straight and still be within that artery. So here are the conclusions of the paper. The paper stated the variability in the location of the major arteries within the temporal fossa, as well as their inconsistent branching patterns among and within patients, impede the ability to classify a safe zone. Okay, so they basically said there's no safe zone deep in the temporal fossa on the periosteum. I'm going to go through a couple of cadaver dissections of the anatomy of the temple. So on the left here, this is, so the superficial temporal artery branches into a frontal branch and an anterior branch. So I'm sorry, a posterior branch and an anterior branch. And so what I'm showing you here is the posterior branch, okay? Now I'm going to show you, this is the anterior branch. The anterior branch is typically the one that is associated with a risk of blindness because it communicates with the ophthalmic system, the supratrochlear and supraorbital. Okay. On the right side, we're going a little deeper. And I'm going to tell you that this is the deep temporal fascia. That deep temporal fascia is quite thick. If you haven't been to an anatomy lab, you need to look at this. It's quite thick. And so when you're putting this gel filler below it, it's asking a lot to push up on that fascia. It is very thick. And I'm going to show you another video. But more importantly, look at all the vasculature laying on the periosteum. Okay, here's one that's cut, and here's several other branches. There's muscular branches and so forth. So there's a lot going on there right on the periosteum, even though it's, quote, safe. So on the left side, this is another specimen, and I'm going to show you, this is the nose for orientation. And this is the superficial temporal artery anterior branch. So it's going off like this, you see, and it's communicating eventually with the ophthalmic system. So here's that posterior branch, okay? I'm sorry. Okay, here we go. So this is the intermediate temporal fat. As I discussed before, it's between the two fascial layers of the deep temporal fascia. And you can see the yellowness of that. And then what's down here? There's another deep temporal artery branch. Okay, so now let's go over to the right side. I'm sorry about that. And the right side, I'm showing how thick that deep temporal fascia is. You see, it's quite thick. And it's asking a lot for HA filler to lift that fascia. So these are the targets that are typically used to inject and enhance the temples. The subcutaneous or superficial fat, which is the lateral temporal cheek fat. The interfascial plane, as I discussed. There are some new studies showing the intermediate temporal fat pad as an injection site, and then the periosteum, which is commonly done. So which is my favorite? The interfascial plane. And I'm going to go through my arguments why that's a good plane. So first, let's go through the different areas and the pros and cons of why they're good or bad. So the superficial subcutaneous fat lies very superficial, and it's superficial to this STA, which is good. But there's also veins in this plane, which is bad. The most important thing that I think is important not to use this plane is that visible product is possible and often seen, okay? There's not a lot of skill to injecting in this plane either. And you can approach this from the hairline, from this direction, from the zygoma, or the superior orbital rim. And you can use either a needle or a cannula. But if you're going to do this, I suggest using a cannula because of the veins there. And the cannulas keep you in the same plane. So this green area here is that target, that superficial fat, okay, also called the lateral temporal cheek fat. So the new area, but this is going to be difficult because you need ultrasound to do this, is that intermediate temporal fat. It's well below the STA, which is good, but it's in the area of the middle temporal vein, which is bad. Okay, there are cases of pulmonary embolus from injections in this temporal vein. It's very unlikely that you'll see visible product, but the skill level is probably the highest because you need to do this under ultrasound guidance. Okay, and you need to use a needle for this because you need to poke through that deep temporal fascia. As I showed you, that deep temporal fascia is a very thick fascia. So that's why you need a needle for that. Okay, and over here, you see the green and you see the middle temporal vein within that intermediate temporal fat. So now this is the layer that most people are doing. They're doing a deep periosteal injection, okay? And it's well below the STA, which is good. But it's in the zone of other arteries, which is bad. The deep temporal artery, the zygomatical temporal artery, as I showed you. There's very unlikely to see visible product, but on the flip side, it's very unlikely to see a result. So, you know, overall, it's easy to do, but it's not as safe as people say, and you don't see much effect. It's very low skill level. It's the easiest skill level to inject that plane than all the others. And there's the one up, one over, which is one up from the superior orbital rim, and then one down from that, okay? I'm talking about 1 centimeter. Or you can angle it up in an angled fashion up from the zygoma into that. And you need to use a needle for this. And I'm showing a portion of what an injection would look like here, and it would probably go up here as well. Keep in mind, there is no plane between the muscle and the periosteum. When you're injecting in that plane, you're basically injecting into the muscle. The muscle is tightly adherent to the periosteum. Okay, so I'm going to show you a couple of these deep injections of patients that I've seen that weren't my injections. Okay, on the left side, you see calcium hydroxyapatite, which is Radiesse, injected into the deep periosteal layer. And you see, as I discussed, it's free floating within the temporalis. And you see it moving because she's clenching her teeth. But you don't see much displacement of the deep temporal fascia either. But more importantly, on the right side, you see that that deep temporal artery is lying juxtaposed to that wad of calcium hydroxyapatite. Okay, so this patient narrowly avoided an injection within that deep temporal artery, which probably would have led to an occlusion and possibly blindness. So this is another injection deeply onto the periosteum, again using Radiesse because it is so visible. And you see how close, that's the Radiesse, you see how close it is to the deep temporal artery as well. So let's talk about the interfascial plane. It's close to the superficial temporal artery, but it's below it. Remember, the artery is within the SMAS, okay? However, there are some smaller arteries, like the zygomatico-orbital artery has been shown in a recent paper to be within that plane. And the sentinel vein is in that plane too. But in general, if you're using cannulas, you can avoid these structures. The facial nerve is in this area, but I've never had a permanent weakness of a nerve during this injection. But most importantly, you need to tell the patient that there will be some weakness of this nerve immediately following the procedure, and they won't be able to raise their eyebrow. And they might think that, oh, that something's gone wrong. No, that's related to the lidocaine in your filler numbing this nerve. It's very unlikely, but not impossible, to see visible product in this plane. It requires a higher skill level, but not quite as high as the intermediate temporal fat. And there's a couple of ways to approach it. I like to come from the zygoma up, the zygomatic arch. You can also come from the forehead down. That is a little bit awkward for me, but Dr. Yanni van Logem loves that approach. If you go down to the periosteum in the forehead, that's contiguous with the superficial layer of the deep temporal fascia, so you automatically get into that plane. And Dr. Harris just showed me an injection entry point that was just anterior to the hairline that he uses too. You should be using cannula for this, and it's a glide plane. And this is that interfascial plane that is labeled in green here. So what I want to show you with this is that HA product lasts a long time in the interfascial plane. So here is HA product. This is the, let's let it cycle a second. So what I'm pointing to with the arrow is the deep temporal fascia, the superficial layer. And then this arrow shows that SMAS layer. And you see within that is the HA product. And over here, I was going to show you, excuse me, is that intermediate temporal fat pad. So what I want to show here is this was a patient that was had a demonstration of a couple different products. And right here is the HA product, which was injected deeply onto the periosteum. And there's another HA product there. And then up here, Sculptor was injected in the interfascial plane. Okay, and then right there is the superficial temporal artery. And you see that it is below the superficial temporal artery, that interfascial plane. So what is my injection technique? How do I do that? First, I do an assessment of the vascular and soft tissue anatomy using ultrasound. Next, I insert the cannula into the interfascial plane using a pinch and pop technique. So just like you're trying to get into the prezygomatic space, you put the cannula through the skin and you pinch it up. That forces you to go deeply and pierce the SMAS. And you should feel a small pop when you pierce the SMAS. Then to correctly identify that you're in the proper plane, I inject a small bolus of saline under ultrasound and confirm it. Once it's confirmed, I change the cannula from saline over to HA without moving the cannula, just taking off the syringes. And then I start to inject with a diluted form of HA product to minimize my chance of visible product. I like to use Restylane. Some people I know are using RHA 2 or 3 for this. You can also use Lift. I like the 1-to-1 dilution. Some people are using it straight. And then after your injection, you confirm the vascular flow again and the placement of the HA or your product with the ultrasound. So what I'm showing you here is getting into that plane with the cannula. You see that little pop that I had? That was piercing through the SMAS. Now I'm in the interfascial plane. You can see the SMAS above and the superficial layer, the deep temporal fascia below. And then you're going to see an injection of saline, and it's going to displace the space and confirm that I'm in that space. Okay, right now, come on, inject. Right there, you start to see it displace. Okay, and so now I am definitely within that space. And over here, you see the pulsing superficial temporal artery. I'm Dr. Steve Weiner, a facial plastic surgeon from Santa Rosa Beach, Florida. And I'm going to show you my ultrasound-assisted technique to enhance the temples. And in this lovely patient, you can notice that there is a slight deficit in her temples right here and right here. And I like to inject the temples with an HA product, and I like to do it in the interfascial plane, which is between the superficial temporal fascia, or the SMAS, or the temporal parietal fascia. It's all those three. And the superficial layer, the deep temporal fascia. It's a glide plane. And I like to start my injection along the zygoma. This is the superior border of the zygoma. This is the inferior border of the zygoma, or the zygomatic arch. Right here, I have the inferior temporal septum. Oh, that's a line drawn from the superior orbital rim to the root of the helix. Often, the superficial temporal artery lies in that inferior temporal septum. Over here, we have the superior temporal septum, or the temporal fusion line. So what we'd like to do is we like to go through the SMAS, or through that superficial fascia, and then inject inside that glide plane. When you're doing ultrasound-guided injections, you need to do it sterilely. So what I like to do is place Tegaderm, which is sterile, over the probe. I'm going to use sterile ultrasound gel as well during the procedure. Place a small dab of ultrasound gel on the probe and then wrap the Tegaderm. So what we're visualizing right here is the superficial temporal artery, the posterior branch. And obviously that is sort of posterior to our field, which is good. So we'll store that. Now we'll look a little more anteriorly. And anteriorly, she doesn't really have that anterior branch of the STA. which is actually really good. That makes this procedure safer, but we wouldn't have known that without discussing. So let me show you the anatomy right. So right here is, this is going to be the skin, this is going to be the bone. Right here is the temporalis muscle. Right here is the intermediate temporal fat pad. So right here is the deep layer of the deep temporal fascia. And here is the superficial layer of the deep temporal fascia. And then above here, this is called the SMAS, or the temporal parietal fascia. So our goal is to get it in between these two fascial layers in that interfascial plane. So we're going to start by using Easy Guide system, 22 gauge, 50 millimeter cannula along the zygomatic arch. And we're using saline here. Okay, and saline's going to prove that we are in the interfascial plane before we inject with the filler. So now she's pinching up to get through the smash, and now we'll get into that plane. So we're using the hockey stick probe now to visualize the cannula. Now we're going to inject some saline. And you see the displacement of the smash, confirming we're in the interfascial plane. Having confirmed that the cannula is in the interfascial plane, we then switch the saline over to the 1-to-1 diluted filler. The injection technique is a slow fanning retrograde injection. The cannula is advanced towards the superior temporal septum or the temporal crest. The filler is deposited as you withdraw the cannula from the temporal crest. It is better to do several passes with small aliquots of filler rather than a few passes with large aliquots, because this prevents visible filler. Since HA has been shown to last several years in this location, it is better to undercorrect and come back for a second injection. When we were satisfied with our correction, we now remove the cannula. What we'll do is we'll finally confirm placement of the filler in the interfascial plane. And there we go. And I'll show you, hit the freeze button for me. And I'll show you the placement of the filler. So down here, again, we have the temporalis. Here's the intermediate temporal fat pad. And right here is the filler. It's between the SMAS layer and the superficial layer of the deep temporal fascia. So this is another example of interfascial plane injection using the cannula. This is a 23 gauge, 50 millimeter cannula. I'm going all the way to that superior temporal septum and doing retrograde technique. I'm doing a wider plane of injection than the prior patient. I'm going past the hairline and doing retrograde injections. This technique also allows you to get into the area of the brow and the supraorbital depression. So I want to mention the key take-home points from my injection technique. Use a large cannula, 22 or 23. I feel the larger cannula have less chance of piercing a vessel than a smaller cannula, smaller gauge cannula. And that's been shown by Dr. Catafana that the 27 gauge cannula is probably as sharp as a needle and can enter a vessel just as easily as a needle. But so this area is a high risk area. So use the larger cannulas, 22, 50 millimeter, 23, 50 millimeter. I like to use a diluted HA product. You can go 1-to-1. You can even go 1-to-2, which will spread the product out even more. I like to confirm the location using saline. And then also consider a second injection so that you don't overcorrect this area. It's a very efficient use of filler in the interfascial plane versus the deep injections. And it's a state-of-the-art for safety concerns. I want to thank you for listening. These are the ways you can contact me. I have a training course, and you can see all the availability at sonosthetics.com. There's my website, my email, and I have a couple Instagrams. So thank you very much, and I'll take your questions now. I'll stop sharing the screen. I can't hear you. Turn your volume on.
Sorry.
There you go. Okay.
Thank you so much, Dr. Weiner. It was very interesting. We have a first question, actually. Do you dilute the HA with saline or lidocaine?
I think that you can use either. The reason why I'm using saline is there is the lidocaine within most of the products. I want to be alerted if the patient is having some discomfort. So as you can tell, the procedure isn't that uncomfortable. So you can add a little bit of lidocaine, but saline seems to be okay too.
Great, thank you. What's the time required for this procedure? Also, do you charge more when using US? I'm not sure.
Ultrasound.
Ultrasound, sorry.
You know, I haven't been charging extra, but it's a good point. I think it's you know, it does take a little more time. I think that typically anyone can do this within 30 minutes. I could probably do it between 10 and 15 minutes. But for the beginner, it might take up to 30 minutes or 45 minutes.
All right. Do you use ultrasound while you are injecting or just before and after?
That's a good question. When I'm injecting, you see that I'm constantly moving the cannula and I'm changing directions. That makes it very difficult for you to follow it with the ultrasound. If you're doing bolus injections, which is a modification of my technique, you might want to do 3 or 4 bolus injections in the interfascial plane and smooth it out. You can do that under ultrasound guidance. But if you're moving around a lot, you cannot do that. Also, the one downside to having the ultrasound on the tissue is you don't get to see the correction very well until you take it off. So in general, I'm not doing that if I'm moving the cannula. If I'm doing boluses, I do it under ultrasound guidance.
All right. Going back to the first question, how do you dilute the HA filler with the saline?
Oh, I'm sorry I didn't show you that. There's a connector, female to female connector. Maybe it's male to male, I don't know. But you add saline in a 3 cc syringe, 1 cc. Then you connect the other HA product to that syringe and inject it into the 3 cc syringe. Then you take another 3 cc syringe and you go back and forth about 20 times. And then you put it back into the syringe that contained the HA. I feel that those syringes are better to inject with than your standard 3 cc syringe.
And someone is asking, why do you dilute the HA?
The only reason I dilute it is because I think it gives a little bit smoother result. Okay, it flows a little smoother. I'm not necessarily stuck on that, and I won't fault you if you don't want to dilute it. I do feel that you're going to lose some of the correction when you dilute it, but you're not going to lose 100% because you're basically hydrating the HA, and HA gets hydrated naturally through the body. So you're pre-hydrating it. By pre-hydrating HA, you actually get a little less swelling. So there's some benefits to that, but that's just what I do. I think a thinner product spreads a little bit and less visible. The one other thing, the temporal skin is probably one of the thinnest on the face. When I measure the skin in that area, it measures between 1.2 and 1.4 millimeters. The cheek is actually closer to 2, sometimes 2.2, 2.4 millimeters, I'm sorry. So it's more easy to see product in the temple than it is on the cheek or other areas.
Right. Any experience with the labia majora filler?
No.
Okay. Can we do multi-layering injections with 22J cannula?
Yeah, but I don't think it's necessary. You can get into the superficial plane and the interfascial plane, but you wouldn't be able to get into the periosteal plane with the cannula. You really need a needle because that deep temporal fascia is too robust to get through with a cannula.
Mm-hmm. All right. Do you use ultrasound guide for every facial zone or just risky ones? Yes, that's one of the questions.
Yeah. So I think I don't do it for all injections. No, I don't. I think that if you're skilled and have experience, that you can get into planes and stay away from trouble, particularly like the prezygomatic space and the submucosa of the lips. But if there's any concern, particularly the nose, the temple, the deep piriform, and plus minus the chin, particularly if you're using needles and deep boluses onto the bone, ultrasound can assist you as to tell you where or if there is an artery in the way that you are injecting.
Mm-hmm. Do you think that by using this type of ultrasound, you can inject hyaluronidase intravascularly in the periorbital or angular artery?
Obviously, yes.
Mm-hmm.
And that's the huge benefit of ultrasound, to take care of vascular complications. Finding the area where the filler is within the angular artery that's blocking and inject directly into the very targeted hyaluronidase. So you can take care of vascular complications a lot easier than randomly injecting it in the vicinity of the vascular occlusion. You can actually inject in the exact location of the vascular occlusion.
Mm-hmm. The ultrasound head can have a guide for a cannula attached to it. Is this something you use, or do you hold the cannula and the head separately? And is it challenging?
I'm aware of what you have, and I actually have a couple in my office that I am planning on trying. Those attachments are quite expensive, though. I think they're a couple $100. So, and they have to be sterile. So that's kind of a inhibitor to use it routinely. There is a skill level associated with holding the ultrasound and injecting under guidance. Keep in mind, no matter how thick the foot plate is, it's about the width of a credit card, your visual field. So it's often best to have actually an assistant to maybe hold the ultrasound and you do the injection while you're looking at the screen.
All right, thank you. Could you please tell us what filler did you use and what is the maximum volumes that you used per side and per session, please?
I like to use in areas where there's a high risk, potentially eye risk as well. I like to use an HA product that is very easy to dissolve. Because if I run into a complication that I need to dissolve, I don't want the HA product to be the limiting factor. I want, so for instance, there are some HAs that are very difficult or harder to dissolve. So I like the less cross-link, the better, and that's Restylane and Lift. And I will inject up to 2 syringes. So that would be, after doing a 1-to-1 dilution, it would be 2 cc's per side, and then bring them back at a later time.
All right. Someone is asking about if you ever use dextrose solution for dilution.
No.
All right. How to obtain the right plane without ultrasound? What are the signs of that?
So the way I discussed going from superior to inferior, so if you go through medial to the temporal crest, the temporal fusion line, if you go medial to that, you go down to the periosteum, and then you glide into the temple, you will automatically be in that plane. You don't, because the periosteum is contiguous with that superficial layer of the deep temporal fascia. So that's one way to do it. I find it a little awkward because you're injecting downward and towards you when you're doing that injection. Yes, when you're injecting this way, you have to feel a little pop through the SMAS. Okay, keep in mind that the SMAS is actually than it is in the temple, so it's not as big a pop as you might think. The other thing is that the cannula should advance very freely. Okay, if there's a lot of resistance, you're not in the right plane because it's a glide plane, because it's between two fascial layers. It takes a little skill to confirm that plane without ultrasound, but you can do it.
All right. What is the risk to penetrate the bone with a cannula?
So you really can't get down to the bone with the cannula. There's too much to go through. That deep temporal fascia is too thick to push a cannula through, particularly a large gauge. So the benefits of doing the deep injections are that it's pretty easy. So, I mean, that's the only benefits that I can see, because it uses a lot of product. The product gets spread out throughout the muscle, and it's very hard to push up on that deep temporal fascia. And it's not as safe as quoted, as the recent paper suggests.
All right. How to remove or melt HA if there is any complication?
Well, obviously you use hyaluronidase. In the United States, we use Hylenex because it's recombinant hyaluronidase, so it's going to have a very, very low risk of having an allergy. And if you're just trying to dissolve nodularity or visible product, you just sort of spread it around the area that you're concerned, and hyaluronidase tends to spread and dissolve it. Another possibility that we're working on potentially is topolase, and that's from SoftFil as well, which is a topical way to eliminate some unwanted product. If it's a vascular or ocular problem, ultrasound would be the best way to do it. Do targeted injections in that superficial temporal artery, the deep temporal artery, supratrochlear artery, supraorbital artery. If you don't have ultrasound, try to get into those arteries by knowing the anatomy. As I discussed, the superficial temporal artery anterior branch is usually in the inferior temporal septum, which is in a line between the superior orbital rim and the root of the helix. So in general, and we find that in our anatomy course that we do monthly, very consistently in that plane.
Is there a chance of occluding STA with cannula in interfacial plane, plane 4?
So there is vascular variability, vascular anatomy variability. But what seems to be fairly consistent is the plane is consistent. So it's typically within the SMAS. It should not be in the interfascial plane. So if you're within the interfascial plane, you should be below the artery. As I discussed, there was a recent paper I evaluated that showed that the zygomatic orbital artery is sometimes within that plane. So it's not 100% vascular free. There is also the sentinel artery sentinel vein too. So that's why there is no safe plane in the temple. There are just what I consider safer planes. The problem is the temple has a lot of vascularity, a lot of hidden structures. So I'm just presenting you one way to do it.
Do you inject lidocaine by needle before HA injection with cannula?
I don't. Some people will at the port of the cannula. Some people use lidocaine with epinephrine because it's easy to see where you started. I would use plain lidocaine. People don't mind that port that much, but if you want to have the best comfort for the patient, you might want to do that as well.
All right, great. I think we have just one last question that is pretty good. Should everyone now do ultrasound beforehand?
Well, I'm trying to get the industry to go in that direction because I'm a huge advocate for safety in injections, and I feel that ultrasound is going to make the whole industry safer. You need to obviously purchase an ultrasound, and you have to learn through a course, and then you have to do, a lot of practicing, practicing on your patients, practicing on your staff, practicing on your family. So I think ultrasound is the future of injecting. Why are all the other specialties in medicine using ultrasound, and why aren't we? We're injecting in the face. We're injecting areas that can cause blindness. Anesthesia is using it for when they inject in the spine, in the back. Emergency departments are using it when they're evaluating gallbladders, gallstones, appendicitis, so forth. So one of the famous sayings, if I'm sticking a needle in it, I'm ultrasounding it first. It was one of my ER friends telling me. So yeah, I think it's the future, and the handheld all-in-ones are very inexpensive. They run from $2,500 to $7,000, and those are adequate for all your needs in aesthetics.
Thank you. We actually have more questions, and if it's okay, I'll keep going. Okay. With radius, what is the right dilution, and what is the correct size to inject temple?
So I would probably do a 1-to-1 dilution as well. I would use the 22 as well. I have what I showed you with radius were deep injections that I didn't perform personally, but I had a patient who had come in and had been injected, and that's what I showed you. I would still prefer that you use a dissolvable filler in the temples because of the risk associated with occlusions and blindness. I can't hear you.
Sorry. What is the complication of injecting hyaluronidase into artery or vein?
There should be no complication with that type of injection other than bruising.
All right. I think we're done with the questions, actually. I hope I didn't forget anyone. Thank you so much, Dr. Weiner. We have so many great comments already. Everyone loved the webinar. So thank you again. To answer everyone's request, the replay will be available on SoftFil Academy's website tomorrow. Everyone will receive an email with the link to the replay, and it will also be on SoftFil's YouTube channel. So
thank you very much.
Yes, thank you
Bye-bye.
again. Bye.
Thank you. Bye-bye.
Everyone.